let's begin with Dr. Steve Arshinoff, who has been a pioneer in many things, but he's going to talk about the organization and how he wants to take up his concept that he pioneered many years ago. Steve, please go ahead.
Okay, thank you, Abe. Let me just share my screen. And I'll put up my talk. Can you see my screen?
Yes.
Yes?
Yes,
Okay.
yes.
Well, thank you very much for inviting me. It's a great pleasure and an honor to be included in this group. I wasn't quite sure what to talk about because I hate saying the same thing over again. So I'm going to talk to you about bilateral surgery, history, future, and some things about indications for FEMTO, because I sent suggestions for 2 talks and Namrata and she put them together. All my disclosures are here and all my other various things on this slide. First, I'll tell you that I have no relevant financial disclosures pertaining to either the Bilateral Surgery Society or to bilateral surgery. And I'll start off saying that, we all recognize that COVID-19 has really changed the world for bilateral surgery because suddenly everyone wants to do it. The main reason is you can do, for example, 20 surgeries in 10 patients rather than 18 surgeries in 18 patients. So the whole thing is more efficient. There are fewer people around to transmit infection. You have fewer OR turnovers, less staff, fewer post-op visits. And bilateral surgery has, by this time, been shown to be safe and effective with quite a few papers from all over the world. Our Society of Bilateral Cataract Surgeons existed from 2008 until 2020. In 2020, we decided at the end of that year to really stop the society and to take our discussion to the main global societies and not amongst ourselves, but we did it before amongst ourselves because no one else was listening. So here are the people who started it on the screen. Interestingly, the group from Finland, Finnish is an unusual language and hard for anyone else to understand. And Suleivi Keipiainen of Jensu was the first in Finland to start doing bilateral cataract surgery. And their work really paralleled the rest of the world put together. And they now do about 1/3 of their cases bilateral cataract surgery and have now published some papers and done some extremely good work. So my idea of things is that I think the natural progression of cataract surgery is to move towards bilateral cataract surgery. And I have this very nice drawing going from the Code of Hammurabi, which was the first document to mention cataract surgery in 1750 BCE, and then with the famous Indian Sushruta in 800 BC having actually described couching. And no one really changed anything for 2,200 years when Daviel, in a really brilliant paper and a brilliant piece of insight, thought we should go to extracapsular cataract surgery. And then the rest you know because it's more recent. But I'm going to tell you a few things you may not know about the history and the ideas and make you think that perhaps bilateral surgery is where we're going to go. So the first thing to say is that in every generation, the methods we use, for example, for cataract surgery, are really extensions of our scientific, and that's in quotes because we don't think that ancient history is scientific, but they thought they were, of their paradigms and what they thought about how things work. This is from a book that we're now writing on bilateral surgery. And one question that came to me when we started to write the book was couching is, whoever got that crazy idea? So one of the things I did was when I was in California once, I went to this Huntington Library, which has a copy of Vesalius's De Humanis Corporis. And I looked at some things and asked if I could see some copies of the papers. And this is one of the illustrations. And you can get it online and it's quite well available. And it shows you this diagram of the eye, which doesn't look like we think it should look like. And it's from the time of the Latins and preceding them and up until 1700, people believed that a cataract was a suffusion of a humor or a fluid in front of the crystalloides, here the lens. And they filled this area with what's called the locus vacuus, and it got filled up and it blocked vision. And the seat of vision was believed to be the lens, the crystalline humor. And that was the rationale for couching. You were really taking a membrane that was solidified from fluid flowing down that came in front of the visual part and the visual sensing part of your eye. And it wasn't until after 1700 that a cataract was demonstrated to really be a clouding of the lens. And that's what gave Daviel the idea of approaching the whole thing differently because of the difference in the concept. And many of you, I'm sure, like me, see patients who come in and they think that taking off their cataract is peeling a cloudy membrane off the front surface of their lens. And that really has its root in these concepts. And it really is quite logical if you believe what this drawing tells you. And to think that in 1540, over 2,000 or 3,000 years after cataracts were first being done and using the same method, that was still the concept of the structure of the eye, is kind of interesting. So then what happened? Why do we perform cataract surgery unilaterally now? Well, cataract surgery was considered to be a rather brutal procedure, and you can imagine it was brutal without anesthetics up until the late 1800s. It was historically actually generally performed with bilateral cataract surgery in the hope that at least one eye might see. And it was often viewed by people as the last medical intervention you would ever get for your whole life. And you hoped to be able to see again, but even more, you hoped you'd survive the brutal surgery. And one of the more famous charlatans, the British eye surgeon John Taylor, routinely performed bilateral cataract surgery, as did most others. And among his patients were the famous composers Johann Sebastian Bach and Friedrich Handel. Unfortunately, Bach died 4 months after his surgery, which was unsuccessful, and he was blind in 1750. So since then, in the late 1800s, the germ theory of disease came into vogue and was discovered by Pasteur. And it wasn't just Pasteur, but for a change, the French, English, and Germans cooperated. And Pasteur thought that rot, inflammation, and disease were caused by invading living organisms. And based on this germ theory, Joseph Lister introduced aseptic surgeries, and Robert Koch then proposed his postulates to prove infectious source and what the actual infectious source was. But it took a very long time before asepsis was accepted because the major powers in medicine at the time didn't agree with this theory. So it was only just after World War I when the germ theory of disease began to be accepted after seeing all the soldiers that were infected on the fronts. And most jurisdictions then began to accept this theory, and it introduced financial and other impediments over the next 20 years to prevent any surgery from being performed bilaterally, including cataract surgery. It was really intracameral antibiotics, first introduced by James Gills and Howard Gimbel in the 90s, that dramatically reduced the incidence of postoperative endophthalmitis and opened the road for us to consider returning to bilateral cataract surgery. So, one of our current paradigms is femtosecond surgery. Modern people want lasers for everything. And I use the catalyst, and Harish Ithyan, one of our students, and all of us in our group, put this paper together where we looked at the difficulty beforehand of performing a cataract surgery, if you had serious exfoliation, a very dense cataract or whatever. And we came up and studying it carefully and assigning careful numbers to all of this, that the more severe the case was going to be, the more they would get benefit from femto. So as opposed to the previous studies showing just huge groups of equal simple cataracts, here we showed just the more severe ones and ranked them and showed that there was a benefit. And I definitely find a huge benefit for dense cataracts because the femto breaks them up. For white cataracts, it does a very smooth, perfect rhexis. For severe pseudoexfoliation, because if the lens is unstable, it can still break up the lens and do the capsulorhexis. For fibrotic capsules, because they are broken up more easily. Myotonic dystrophy patients, a rather rare group, have extremely elastic capsules, and you end up pulling outside the eye before the thing starts to break. And for posterior polar cataracts, it leaves a thicker layer of cortex behind the nucleus and breaks up the nucleus. And so you can do the operation more easily in steps, and you end up doing better and leaving the aperture that is broken in the posterior capsule. The problem with femtos is historically they had more anterior capsular tears. Initially it was 10%, eventually fell to 1.84%, and now it's falling down and down, lower and lower. And one of the things I did was I wrote this paper talking about that flax really is no different from hypermature cataracts. In hypermature cataracts, we have intracapsular pressure because of necrotic lens material. And in flax, we have gas inside the bag. And it really is the same thing. And you do both of these by placing pressure in front of the capsule equal to or higher than the pressure behind it. And this is a paper we wrote, and here it shows you a technique of how you inject the OVD in front of the capsule, where you see there are areas here that haven't been broken by the laser. And you then take one of these very fine, I use the Haldeperker masket forceps, and I press posteriorly actually the same method Jim Gills used to use for his capsulorhexis, because when you press posteriorly and centrally, the capsule will tend to tear towards the center, not towards the periphery. And if you pull the capsule in that way, you get it totally free. You then just pick it up and take it out, and you get down to very close to 0 capsular tears. So the future. Well, recently, as concepts change around the world and published data supports bilateral surgery, where appropriate precautions are taken, some national guidelines, e.g. the American, the British, Irish, Royal Australia, New Zealand College of Ophthalmologists, and Canada have become much, much more positive about bilateral surgery, and in some cases even encourage it as an effective strategy in the pandemic and post-pandemic times. So I think the summary is that the history of cataract surgery, if you look at it more carefully, reflects the paradigm of the times. And ISBCS is a natural evolution of cataract surgery, and the trek to FEMTO has begun, and I think we will all slowly move that way, although there are many impediments along the road, like there have been everything else we've done. And throughout history, bilateral surgery was the most common method for cataract surgery, except for the 100 years of the 20th century, when we understood but couldn't control infection well. And it's curious that another infection caused bilateral surgery to change and go back to bilateral surgery, COVID-19, which is really, if you look at it carefully, a monetary incentive, where before we had monetary incentives everywhere against bilateral surgery. Now we have monetary incentives towards bilateral cataract surgery, and we're going back to what we were doing before. Thank you very much.
Thank you, Steve.